I am Ibrahim Abu Bakr, Professor of Andrology and Reproduction, Mansoura University. Today we will speak on the sexual medicine. This is my contact details. I hope at the end of this unit the student will be able to define different sexual dysfunctions, to list the etiological factors, to take clinical history, to perform clinical examination, and to request investigation for different cases, and to treat cases of the different sexual dysfunctions. At first, let us read this scenario. 60-year-old man married since 30 years, presented with weak erection and inability to penetrate vagina of the woman, and he is under treatment for diabetes mellitus. How can you arrive at the diagnosis of this case, and how can you treat? On the other hand, a 30-year-old man married since 1 week, presented with a weak erection and inability to penetrate vagina also, and he is not under treatment for any disease. How can you arrive at the diagnosis, and how can you treat? In general, sexual medicine is a science that deals with the study of the human sexuality and sexual dysfunction. Before we are going to discuss the clinical part, let us discuss some physiological points. The first point is the physiology of sexual act. It is also known as physiological sexual response cycle. Physiological sexual response cycle includes all biological responses that occurring in both man and woman during sexual stimulation. This includes vascular changes, endocrine changes, neurological changes, and psychological changes. These changes were described by William Master and Virginia Johnson in 1960s. These authors described these changes and classified the changes into 4 phases. The first phase is excitement phase or arousal phase. Second phase is plateau phase. Third phase is orgasm. And the last and fourth phase is resolution. This is Master and Johnson. These 4 phases are preceded by a first phase is called the desire phase. But because it has ill-defined duration, it is not listed among the 4 phases. Let us summarize the changes that occurring during these different phases. The first phase, the sexual arousal phase, characterized by erection in the man. What is erection? Erection is filling of the penis with blood during sexual stimulation. Erection, rising of the testes and thickening of the scrotum. In the woman, there is increased vaginal lubrication and swelling of the labia. And in both man and woman, there is increased basal parameters. Basal parameters include heart rate, respiratory rate, temperature, and the blood pressure. And there is associated sexual flush. Sexual flush means erythema of the face during sexual stimulation. The plateau phase characterized by rigid erection and small secretion from the Cooper's gland. And in women, there is more vaginal lubrication and the development of what is called orgasmic platform. What is orgasmic platform? Is dilatation of the upper part of the vagina and constriction of the lower part of the vagina. Both men and women develop increased muscle tension and there is sensation of impending orgasm. Orgasmic phase means the phase associated with pleasurable sensation of the sex. In men, it occurs in association with ejaculation. Ejaculation means expulsion of the seminal fluid into outside. And in women, orgasm is associated with contraction of the uterus, vagina, anus, and pelvic muscle. And in this phase, there is highest basal parameters and sexual flush spread all over the body, and there is loss of the muscle control. The last phase is the resolution phase. It is associated with return of all these changes to normal. It means the loss of the erection, decongestion of the pelvic viscera, and return of basal parameters to normal. However, there is whole body sweating because sexual activity is a form of the physical exercise. But there is two important points are occurring during the resolution phase. The first point is refractory period. It occurs in men only. Refractory period means inability to respond to any sexual stimulation, whatever it may be. And the period of this refractory period differs according to the age. And cervical opening to allow movement of the spermatozoa into the female genital tract. So, sexual response cycle start by the desire, excitement, plateau, orgasm, and resolution. What is the difference between ejaculation and orgasm? Normally, in normal persons, both orgasm and ejaculation occurs together. However, they are two different physiological processes. Ejaculation means expulsion of the semen into outside, and orgasm means pleasurable sensation felt in the brain. The next physiological point is the mechanism of erection. Erection is filling of the penis with blood under the action of the neurotransmitters. So it is a neurovascular event. It is a reflex action characterized by stimuli, afferent, center, efferent response. Stimuli may be centrally acting, those coming from the eye, nose, ear, and brain, or peripherally acting, those coming from touching of the penile skin. The center in the sacral segments 2, 3, 4, it is parasympathetic center. The most important neurotransmitter released at the erection is the nitric oxide. Acetylcholine play a role. The response in the reflex erection characterized by relaxation of the smooth muscle fibers of the corpora cavernosa of the penis under the effect of the nitric oxide and acetylcholine, leading to increased blood flow to the penis, leading to erection, associated with the mechanical venous occlusion to decrease the blood coming out from the penis. The penis generally is formed from 3 corporal bodies. 2 corpora cavernosa are present dorsal, and 1 corpus cavernosum present ventral. The urethra bears the corpus spongiosum, and as the distal part of the corpus spongiosum, it distends distally to form the head of the penis. It is called the glans penis. The urethra in men is divided into 2 major parts. The penile urethra, it is called also the anterior urethra, and the posterior urethra. Posterior urethra divided into 2 parts. The part passing through the prostate is called the prostatic urethra, And the membranous urethra is the part of the urethra between the penile urethra and the prostatic urethra. Penis is a vascular organ, so it has very dense venous drainage system, three systems of venous drainage: superficial, middle, and deep venous drainage systems. The corpora cavernosa and corpus spongiosum are formed from blood spaces. They are distended with blood during erection. These blood spaces are called blood sinusoids. Blood sinusoids are supported with connective tissue pillars. Each blood sinusoid is lined by endothelial cells. Endothelial cells produce endothelial nitric oxide as a neurotransmitter to help to maintain erection during the sexual activity. And the lining and the wall of the blood sinusoid. The most important component of the wall of the blood sinusoid is smooth muscle fiber. Smooth muscle fiber will relax during erection, contract during flaccidity. The other components of the wall include nerve fibers and collagen and elastic fibers. During erection, the blood sinusoid distend with blood and will press on the emissary vein against the tunica albuginea to decrease the venous return from the penis. This is called venous occlusive mechanism. And during flaccidity, the venous occlusive mechanism is aborted, so there is free venous return out from the penis. The ejaculation reflexes include three components: emission and bladder neck closure occurring together and are under the sympathetic control, thoracic 10 to lumbar 2. Emission means the expulsion of the semen into the posterior urethra, and the bladder neck closure occurring to prevent regurg of the semen into the urinary bladder. The third component is called ejaculation proper. It is expulsion of the semen from the posterior urethra outside. This is occurring by contraction of the pelvic muscles, and it is under somatic sacral control, sacral segment 2, 3, 4. The most or the main disease in sexual medicine is called erectile dysfunction. Erectile dysfunction means consistent inability to achieve or sustain penile erection of sufficient rigidity for sexual intercourse to the point of satisfaction of the both partners. The old name of the erectile dysfunction is called impotence. Impotence or erectile dysfunction is caused by many causes, ranging from psychogenic causes to mechanical causes, passing through vasculogenic, neurogenic, endocrinal, metabolic, or iatrogenic causes. For example, psychogenic causes include the depression, performance anxiety, relationship problem, lack of sex education. What is meant by performance anxiety? Anxiety occurring during sex from different types of fear. Vasculogenic causes include the ischemic heart disease, atherosclerosis, peripheral vascular disease, hypertension, hyperlipidemia, and smoking. Neurogenic factors includes any disorder or disease or lesion affecting the pathway of the erectile function, including cortical lesion, multiple sclerosis, Parkinsonism, multiple system atrophy, peripheral neuropathy, and spinal cord lesions. Endocrinal causes, including any endocrine disease that can cause hypogonadism, that can cause deficiency of testosterone. So deficiency of testosterone can lead to erectile dysfunction. One of the causes, endocrinal causes that can lead to hypogonadism is the hyperprolactinemia, adrenal disorders, hypothalamic and pituitary disorders, hyper and hypothyroidism. Metabolic causes. The most frequent and the most common organic cause of the erectile dysfunction is diabetes mellitus. Other metabolic causes include the renal failure, chronic liver disease, alcoholism, hemochromatosis. Iatrogenic causes means either drugs causing derangement of the pathway of the erectile function, or surgery causing damage to the nerve pathway or the blood supply to the penis. So it may include all radical surgery in the pelvis. Mechanical causes include congenital penile deformities or penile fibrosis, which is called the Peyronie's disease. Peyronie's disease is acquired penile fibrosis, may cause erectile dysfunction and may cause bending or penile curvature. Huge hydrocele can counteract with the erectile function and also cancer penis. Like any medical disease, diagnosis of the erectile function depends on the clinical history, clinical examinations, and investigation. Clinical history also looks like any general medical disease, composed of the personal history, present history, past history, and family history. But the most important during the process of the history taking of a case of the erectile dysfunction or sexual dysfunction in general is sexual history and reproductive history. The most important points in sexual history and reproductive history includes the special habits, onset, course, duration of the complaint, in asking about inability to initiate and or maintain erection, asking about sexual desire, ejaculation, and orgasm, asking about nocturnal or night erection or morning erection, asking about the sexual orientation, asking about previous treatment, and asking about the marital relationship problems. The most important points in examination include height, weight, signs of the hypogonadism, like gynecomastia, hair distribution, the voice, and so on, perineal sensation, perineal reflexes, feeling dorsalis pedis pulsation, measuring the penile size, looking at the position of the meatus, examination for penile plaques or deformities, examination for the testicular size, consistency, and varicocele, looking for scars of previous operations. However, full history taking, including all these points in front of you in the slide, and also full examination including all these points when you look at the slide. After taking a history and performing examination, you are now being able to differentiate between psychogenic and organic erectile dysfunction using this criteria. Criteria include the onset, circumstances, course, nocturnal and early morning erection, non-coital erection, and anxiety and fear. For example, the onset acute in psychogenic erectile dysfunction. It is gradual in organic erectile dysfunction. The course is intermittent in psychogenic and progressive in organic erectile dysfunction. Nocturnal and early morning erection are present normally in psychogenic but become poor in the organic erectile dysfunction. Investigations for a case of erectile dysfunction may include investigation to confirm the diagnosis, investigation to search the etiology, investigation to assess the type and the degree of the erectile dysfunction. To confirm the diagnosis, proper history and proper clinical examination can help to confirm your diagnosis of erectile dysfunction. In addition, you can use a questionnaire of the International Index of Erectile Dysfunction. It is 15 questions. Also, you can use intracavernous vasoactive drug testing. Vasoactive drugs are a group of drugs when injected into the corpora cavernosa can induce artificial erection, are used to confirm the diagnosis of the erectile dysfunction. Investigation to search the etiology include urine and blood sugar, lipid profile, hormonal assay, mainly total testosterone and serum prolactin. Also, you can need to examine for psychiatric disorder, neurological disorder, and cardiovascular disorder. So, psychiatric, neurological, and cardiovascular consultation may be needed. Investigation to assess the type and the degree of the erectile dysfunction may include the penile color duplex ultrasound examination, cavernosometry and cavernosography, internal pudendal arteriography, and Rigiscan monitoring of night erection. It is called a nocturnal penile erection or night erection. These are physiological erections occurring at night in normal person. So we can summarize specific diagnostic tests for the erectile dysfunction case in the form of vascular studies, included the intracavernous vasoactive drug injection testing, penile dynamic color duplex examination. Dynamic means color duplex examination in combination with the injection of the vasoactive drug. Penile dynamic infusion cavernosometry and cavernosography. Also, dynamic means performing cavernosography and cavernosometry in combination with injection of saline or vasoactive drug into the corpora cavernosa during the test, and internal pudendal arteriography. So there is 4 vascular testing and 3 neurological tests, including the biosessiometry, bulbocavernous reflex latency, and nerve conduction velocity. In addition to Rigiscan monitoring of the nocturnal penile erection and endocrine studies, as previously mentioned, such as the serum total testosterone and the serum prolactin. Drugs used for intracavernous injection are group of drugs, including 4 drugs: papaverine hydrochloride, prostaglandin, the synthetic form of the prostaglandin E1 is called alprostadil, in addition to the phentolamine and atropine sulfate. This is papaverine, and this is the prostaglandin A1, alprostadil. Injection will be in the mid shaft of the penis, of the penis. Injection will be on one side only, either on the 2 o'clock or on the 10 o'clock. Injection will be, I repeat, on one side only, because there is communication between, this is the septum in between the 2 corpora cavernosa, but this septum is incomplete. So there is communication between the 2 corpora cavernosa. So injection will be on one side only. Positive test means good erection, and when good erection occurs, it will signify there is no significant vascular lesion. However, intracavernous injection is associated with different side effects, including prolonged painful erection called the priapism. Fibrosis is associated mainly with the papaverine. Injury of the nerve or blood vessel. Pain, which is associated only with prostaglandin A1. And transient hypotension due to escape of the vasoactive drugs from the penis into the circulation. This is the Rigiscan device. It is a computerized device used for monitoring of the erection occurring during night, which is called nocturnal penile tumescence or nocturnal penile erection. The device is provided with 2 loops. One loop is wrapped around the tip of the penis, and the other loop wrapped around the base of the penis. And the patient is allowed to sleep in the hospital at least 8 hours nightly. And the device is wrapped around the thigh of the patient. And in the morning, the technician will print the report. The report will give you the number of rigid erection and the rigidity of the erection. The number of the times of the erection and the rigidity of the erection. Also, we can use the color duplex ultrasound to examine for the hemodynamics parameters to evaluate vasculogenic erectile dysfunction. The most important parameters measured during the color duplex examination is the peak systolic velocity, end diastolic velocity, and resistant index. This is the peak systolic velocity, end diastolic velocity, and the resistant index can be calculated from these figures. This is the Cavernosometry. It is a device used to measure the intracavernous pressure during flaccidity and during the erection. The device is connected with the patient through the microcatheter or through a butterfly needle, cannula. Dynamic also means the induction of erection after connection with the device. This is the cavernosography. Cavernosography means X-ray examination of the penis after injection of the contrast material. You see in this picture leaking veins due to leaking of the contrast material from the penis. This indicates venous leakage or venous occlusive disorder of the penis. This is the case of the pudendal injury, diagnosed by the internal pudendal arteriography due to pelvic fracture. Biosessiometry device. It is a device used to examine for the vibration sense of the penis. This is the probe, and you can examine at these areas, as the shaft, at the glans penis, at the frenulum. The treatment of erectile dysfunction can be classified into the following points. You have to treat all curable or reversible causes of the erectile dysfunction, such as the hypogonadism, hyperprolactinemia, hyperlipidemia. You can correct the correctable risk factors, such as the taking drugs, smoking, and obesity. You can educate and counsel the patient. You can instruct your patient to take psychotherapy or behavioral therapy when needed. So, etiological treatment may include the testosterone therapy for hypogonadal patient and dopa agonist for patient complaining of the hyperprolactinemia. Symptomatic treatment can be classified into first-line therapy, second-line therapy, third-line therapy. The first choice of therapy, of symptomatic therapy for erectile dysfunction is oral pharmacotherapy, mainly phosphodiesterase type 5 inhibitors. The second-line therapy includes the intracavernous injection of vasoactive drugs, intraurethral injection of vasoactive drugs, topical application of vasoactive drugs. Third-line therapy include the arterial or venous reconstructive surgery when there is venous leakage, for example, insertion of the penile prosthesis, or using a vacuum constriction device. In some details, oral pharmacotherapy include phosphodiesterase type 5 inhibitors such as the sildenafil, tadalafil, vardenafil, and avanafil. The principal mechanism of action of these drugs depends on the presence of sexual stimulation and the presence of the nitroergic nerves or non-adrenergic, non-cholinergic nerves, releasing the nitric oxide, which is the most important neurotransmitter of erection. Nitric oxide, by another mechanism, will increase the cyclic GMP, cyclic guanylate monophosphate, in the smooth muscle fibers or smooth muscles of the corpora cavernosa. Increased concentration of cyclic GMP will induce relaxation of the smooth muscle fiber, leading to erection. This occurs because the phosphodiesterase type 5 drugs, type 5 inhibitors, will inhibit the phosphodiesterase type 5 enzymes. Inhibition of these enzymes responsible for breakdown of cyclic GMP will lead to accumulation of cyclic GMP, leading to relaxation of the smooth muscle and leading to erection. The second line therapy include intracavernous injection of the vasoactive drugs, either papaverine or prostaglandin or combination, or use of the intraurethral or topical vasoactive drugs such as the alprostadil, which is the prostaglandin A1. Intraurethral vasoactive drugs are inserted into the urethra through applicator, and the prostaglandin will diffuse to reach the corpora cavernosa to induce erection. The third line therapy include arterial or venous vasoconstrictive surgery, and include also penile prosthesis. Penile prosthesis can be classified into 3 types. The first type is rigid penile prosthesis, which is continuously erected, made from silicone. This is no longer used. The second type is the malleable penile prosthesis. It can be erected and it can be relaxed or induce flaccidity of the penis after insertion of the penile prosthesis. This is the most commonly used type. The third type is called the inflatable penile prosthesis. You can fillet through a pump. You can fillet the penile prosthesis inducing erection, and deflate penile prosthesis inducing the flaccidity. Penile prosthesis can be inserted into the corpora cavernosa of the penis like this. The last modality of treatment of erectile dysfunction is vacuum constriction device. The idea of the use of vacuum constriction device is to induce suction pressure over the penis to suck blood from the circulation, like this. And we lift a band at the base of the penis to keep the blood in the penis until the end of the sexual activity. Now we come to discuss another disease, premature ejaculation. Premature ejaculation is a male sexual dysfunction characterized by ejaculation that occurs before or within 3 minutes of vaginal penetration, and is associated with inability to delay ejaculation, and associated with the marked personal distress in both man and woman. The causes of the premature ejaculation are many, but the most important cause in primary premature ejaculation includes neurobiological defect in the brain characterized by decreased serotonin or anxiety. Organic causes, especially in secondary premature ejaculation, may include the erectile dysfunction, genital infections, and the hypogonadism. Delayed ejaculation. Delayed ejaculation means persistent or recurrent delay of ejaculation in spite of normal sexual stimulation. The causes of this disorder include different psychiatric disorders, diabetes mellitus, peripheral neuropathy, spinal cord injury, associated also with the use of the different antidepressant, tricyclic antidepressant, serotonin reuptake inhibitors, or MAO inhibitors. In some cases, there is no cause, so it is called idiopathic. Retrograde ejaculation. Sometimes you are confronted with a patient complaining of dry orgasm. Dry orgasm meaning patient feel orgasm during sexual activity, but there is no antegrade ejaculation because the semen is pushed back to the urinary bladder. It can be diagnosed by urine analysis after sexual activity to find spermatozoa in the urine. This is caused by the bladder neck disorder, and treatment will be treatment of the cause. Peyronie's disease. Peyronie's disease is a connective tissue disorder characterized by formation of fibrous plaque in the tunica albuginea of the penis, and this fibrous plaque can extend into the corpora cavernosa and the corpus spongiosum. This disease, Peyronie's disease, characterized by significant penile deformity or penile bending or penile curvature. Also, the patient can present with the penile pain during the inflammatory stage of the disease. Also can present with the erectile dysfunction or shortening of the penis due to contraction of the fibrotic part of the penis. The pathogenesis of Peyronie's disease may be attributed to the repeated injury to the penis during the repeated sexual intercourse. However, there is genetic predisposition. The condition can be diagnosed during clinical examination, can be diagnosed with duplex examination, with or without injection of the vasoactive drugs. Treatment may include medical and injection therapy like alpha agonist, can include the traction therapy for the penis, and can include surgery for the disease, including the removal of the fibrotic plaque and the graft insertion. This is the fibrotic plaques on the dorsum of the penis, causes bending of the penis upward. Fibrotic plaque in the tunica albuginea and extend into the corpus cavernosus. Priapism. Priapism means persistent, prolonged erection, usually painful and occurring without sexual stimulation. Usually it is uncommon disorder and it is a medical emergency. We have two types of priapism: ischemic type and non-ischemic type. Ischemic type usually caused either by sickle cell disease, leukemia, or drugs such as the intracavernous drug testing. High flow type usually due to trauma of the blood vessel linked to high flow into the corpora cavernosa. The condition can be diagnosed with the color duplex examination of the corpora cavernosa or blood gas measurement of the blood from the penis. Blood gas measurement can help to differentiate the ischemic type and the high flow type. Treatment usually we start with the conservative treatments such as the ice packs, blood aspiration, or drugs, especially the alpha agonist. Conservative treatment used in early cases. However, if the patient is coming to you after many hours, you have to refer for surgery. Surgery may include shunt operation. Dear students, at the end of this lecture, you can read the summary of this lecture commenting on the erectile dysfunction. The most frequent psychogenic cause of erectile dysfunction is performance and anxiety. The most frequent organic cause is diabetes, and the aging is the absolute most frequent cause. Premature ejaculation is one of the most common male sexual dysfunction. Priapism is uncommon, associated with prolonged painful erection. Biron disease is a connective tissue disorder characterized by formation of the fibrous plate of the penis leading to erectile dysfunction and the bending of the penis. You can read these questions and their answers. Please read carefully, and you can read these references. And if you have any question, please don't hesitate to contact me at my communications previously mentioned, and